Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of hand pathology. Dr. Travis Brown, I wanted to sort of crack my fingers like a pianist sitting down, but I don't like doing that.
Well, it's good. I get asked by my kids actually if does that actually cause any problems, because clearly when kids start cracking, everyone says, oh, that causes arthritis or something like that, and I have to say no, it doesn't. But yeah, it is. We're discussing hand pathology. We're trying something a little bit different this time. We've got a Paul, who's our hand surgeon, who's coming along, and I've decided to throw out him a few topics to run through it. So this is osteoarthritis of the hand, ganglion cysts, and carpal tunnel syndrome, and it's just trying to get a few topics together for our listeners to say, here's what we need to know about it. But I want to raise this with two historical figures that to show how common this can actually be, particularly in history. And the first is Leonardo da Vinci. And so he was believed to be ambidextrous. And so his little quirk was that he could draw with both hands. He used to often write backwards, so you could see it in a mirror, which is a sort of an interesting little party trick, I guess. I'm not quite sure why he did that, but he could actually... now, it's said, though, it's claimed that he only painted with his right hand. And so later in life, Leonardo had difficulty using his right hand. Now, it's said that he struggled to hold palettes and paintbrushes in his right hand. And there is actually a red chalk or a sanguine portrait of where Da Vinci, it's done by Giovanni Figino, who's actually got this sort of it's an older Da Vinci, and it shows an elderly man with his right hand, it's almost in a sling, and it's in this the right hand's in this contracted pose. And this has sort of created some conjecture. And there was a visit to Leonardo da Vinci when he was about 65 years old by Antonio de Betis, where this was written about his presentation.
One cannot indeed expect any more good work from him, as a certain paralysis has crippled his right hand. And although Messer Leonardo can no longer paint with the sweetness which was peculiar to him, he can still design and instruct others.
And so there's theories as to his health. Like some believe he had a stroke and that this was caused it, but there was no actually mention of any other part of his body that has been affected, like sort of, a facial droop or anything. So this was confined to his right hand. This could have been Dupuytren's contracture. This could have been, people theorize it could be ulnar palsy. And so we don't actually have much, but something was certainly wrong with his right hand. And then that brings us to Michelangelo. So around the same time. Now, it doesn't need any intro, much like Leonardo, but there is portraits of Michelangelo in his 60s, and this was showing lumps and bumps on his left hand. And people have actually studied the portraits, and they've looked at, even there's been an article by Lazzeri in 2016 from the Journal of the Royal Society of Medicine.
The portraits show Michelangelo's hand to be affected by degenerative arthritis. These are clear, non-inflammatory degenerative changes which were probably accelerated by prolonged hammering and chiselling. The possibility of ganglion swelling at the dorsal side of the trapezius metacarpal joint or metacarpophalangeal joint is less likely because it would be expected at the flexor tendon side. It remains still unknown if the suspected but unproven uric acid metabolic dysfunction may have contributed to these changes that are without evidence of tophi and are clearly not inflammatory. Michelangelo's difficulties with tasks such as writing may have resulted from stiffness of the thumb and the loss of the ability to abduct, flex and adduct it. The swellings at the base of the thumb and the swellings of the smaller joints of the thumb and the index are not gouty in origin. They may be interpreted as osteoarthritic nodules.
So this analysis, as of course you would expect, is heavily reliant on the interpretation of paintings, of sketches and things. So look, there's no way to confirm any of this. It's all conjecture. It's interesting. I mean, this is, an academic discussion, so I love hearing about it or reading about it. And the ganglion cyst that's mentioned, there's an literally old school treatment where they used to get, it's called the Bible bump. No. And they used to actually get big, heavy Bibles and smack it on the back of people's hands to burst the cyst. It was called the Bible bump. And so now that's not recommended. Wow, we'll talk to our guest about that as well. But look, this is where our discussion is today. We're wanting to find out more about it. And again, if these painters live today or these artists live today, our treatment would have been so much different. Their lives would have been so much different. And this is the power of modern medicine.
And the power of the King James method. Dr. Paul van Minnen is a plastic and reconstructive surgeon who studied medicine and received his PhD from Utrecht University in the Netherlands. Dr. van Minnen qualified in plastic surgery in the Netherlands before coming to Australia, where he completed 3 years of advanced fellowship in reconstructive microsurgery, burns surgery and hand and wrist surgery at the Royal Adelaide Hospital and Flinders Medical Centre. Dr. Paul van Minnen runs his own private practice in Adelaide called Grip Surgery and is a returning guest here on this Medical Life podcast. Paul, welcome back.
Hi, Stephen Travis. It's good to be back.
First of all, just how common is osteoarthritis of the hand?
Yes, it's common. I think it's about a third of my practice in hand surgery. And if you look at what the studies say, there's been a recent study that looked at the prevalence of osteoarthritis of the hand. In people over 66 years of age, about 40% of the females and 25% of the males will have some form of osteoarthritis. There's actually been an interesting study from my home country in the Netherlands. They looked at 5,000 x-rays of the general population, people without and with hand symptoms. And in the population over 55 years of age, about 40% of the people showed arthritis of the base of the thumb. So on x-ray only. But doesn't mean that everybody was symptomatic. About a fifth of those had symptoms. But if you're over 55, you take a random person x-ray, you'll see about 40% will have some arthritis of their thumbs.
Is that across the general population or just people who played AFL and cricket?
Yes, no, that was the actual general population. So 5,000 people, general population over 55 years old. And if you look, you'll find arthritis in a large proportion of them.
What are some of the common clinical presentations with people?
It varies greatly. It depends on how hard you look. So some people come to see a doctor with just a tiny bump on a joint in their finger without pain or stiffness. That's like the mildest form you'll find. And some people arrive with two hands with multiple joints that are crooked, pointing the wrong way with pain and stiffness. Now, I think the most common presentation would be a patient that comes with one or two stiff or painful joints with some swelling and maybe some crookedness. And that's usually the stage where I will see people in my practice. But I'm sure that a GP will see people with sort of milder forms.
So what are Heberden's or Bouchard's nodes? I probably haven't said that right because it's been a long time since I've actually come across those words.
Yeah, so it's Heberden and Bouchard. Yeah. But so they're actually both the same thing. They're sort of bony bumps called osteophytes, and an osteophyte is like a symptom of an arthritis joint. And it depends on what joint they're on. So if you look at your fingers, the joint closest to your fingertip is called the DIP joint, the distal interphalangeal joint. If there's a bony bump there, it's called a Heberden nodule. And if you go one joint further up your hand, the PIP joint, it's called a Bouchard's node. So they're basically the same thing twice, but depending on what joint you find them on.
Who gets these nodes then?
Yeah, so anybody with osteoarthritis can develop these nodes. I'm sure everybody would have seen a family member or a person they've known. You look at their hands and you see these bumps. So yeah, anyone who has osteoarthritis of their finger joints can actually get these Bouchards or Heberdens. You see more Heberdens nodes than Bouchards, so the DIP joint's more frequently involved. But yeah, you would have seen them, and anybody is susceptible of getting them if you get arthritis of your finger joints.
Do they have any clinical significance other than just noting, oh, that's going to be osteoarthritis?
Not really. They're rarely painful, the nodes themselves. People find them unsightly. And quite frequently people come and ask, like, can you just get rid of this because I don't like the look of it? Like my mom had them and I didn't like the look of them, and now I'm developing mine, and can you shave them down or do something? Yeah.
Do people actually go ahead and get them shaved down?
I usually advise against it. So if they come and see me for pure cosmetic reasons, wanting to shave down these nodes or want an operation, I usually say, let's not. Let's see how your arthritis develops. And if there is pain, which is a good reason to intervene, or functional trouble, like a proper crooked joint or a stiff joint, then I think surgery is more warranted than the look alone.
Now, how does osteoarthritis of the thumb approach different to fingers?
It's very different. Like the thumb is a completely different ray when it comes to hand function than fingers. I think the general principles always still apply. So always try non-surgical options first, as far as it will go, and then consider surgery. Now, in the thumb, if you choose to operate on it, it's usually a bigger deal. The procedure is usually more involved and recovery takes a bit longer. So I think there is a bigger role for non-surgical treatment options for the thumb than there is for fingers. I usually try hand therapy for just a little bit longer, or try some other modalities for just a bit longer before you choose to operate. And then when you choose to operate, there's usually different choices depending on what joint of the thumb you're working on.
What are some of the non-surgical treatments that are involved?
Of all the people I see in my practice with hand osteoarthritis, I think the majority doesn't require surgery because the non-surgical treatment options, they work. If you go down the list from the easiest things to do to the more complex things, like modify your use. If you find particular tasks in your lifestyle are causing you pain and trouble, just try to avoid those. Now, that's easier said than done because people just want to play their sports and they want to go and garden. So, I don't really like giving that advice, and try other ways so that people can keep doing the things they like. So, modify your use is one. You can use anti-inflammatory drugs if you try, so some ibuprofen maybe to take the edge off the pain. But I think more is usually needed. And I think a first good stop is to see the hand physiotherapist or the hand therapist. They can really help. Things like compression therapy, like wearing a compression sleeve on your finger overnight, for example, can help with your sleep quality, but also the comfort during the day. And if hand therapy doesn't work, then you can consider getting a cortisone injection in your joint. And if all those fail, then you should consider an operative approach.
Who does the cortisone injection? Would that be a surgeon or would that be someone? Because the sticking needles in joints is always a dicey area.
Yeah, and the joints in the hand are quite small to target. So you either have to know exactly where you're going. And if you're confident you can do it, I think an ultrasound guided cortisone injection is the way to go. So a radiologist can do that for you. And in my practice, I prefer to refer people to the radiologist to get it done that way. You could try it yourself, but I would recommend against it because oftentimes you miss and it gets painful or unpleasant. So radiology is your first call for the cortisone injections.
Now, when should doctors actually refer for a surgical assessment or consideration?
Yeah, so if the non-surgical options fail. Now, that said, I think most hand surgeons would be very happy to see patients with very mild symptoms of very mild arthritis just to discuss these treatment options with them. But in general practice, I think try the activity modification, maybe some non-steroidal inflammatory drugs for a while. A hand therapy referral can be done too, but if all that fails, I think a hand surgery referral should be considered. And surgery are good. There's good options there.
So, what are some of the surgery options when you're looking at patients?
Yeah, I hope you've got some time. There's lots to say about this. So roughly speaking, joints can be replaced or joints can be made stiff. That's called a joint fusion. That's broad strokes, and it much depends on what joint you're talking about. If you like, I can talk you through. Like if we start at the most distal joint, so at the fingertip, that's the DIP joint. If that one becomes painful or stiff or crooked, you can fuse the joint, which means cleaning out the joint surface, take away the Heberden nodules, make the joint look all pretty and straight, and then make it stiff with a pin or a screw. That's called a joint fusion. Now, that means that you won't be able to move that one particular joint of your finger anymore, but you get a pain-free, stable, good-looking joint in return, and people usually don't miss it. That last bit of flexion, for example, of the DIP joint. So that's that one. I think a joint fusion is a good procedure. If you move one joint up, the PIP joint, so the one that sits in the middle of your finger, that one is very important to keep moving, to make a fist or to pick up a grocery bag or do something useful. You have to have some movement in the PIP joint. So that's a great joint to consider for a replacement. It looks like a mini knee joint, for example. So you get all sorts of types of implants. You can get like a metal Teflon one or a pyrocarbon one or a silicone one. And that way you can remove the painful joint and replace it with a joint implant and keep this finger moving without the pain. Now, that said, movement is oftentimes not as good as a normal healthy finger, but patients will appreciate the pain relief they get with a bit of movement continued in that joint. Now, then one more joint up, which is the MCP joint. It's the big one when you make a fist, these big knuckles. Those are often not involved in osteoarthritis, more so in rheumatoid arthritis. But if they do get involved, you can replace those joints too, or fuse them, depending on what the patient is after. So thumbs are different, right? So if we move one joint up, at the most distal joint of your thumb, so the fingertip one, that's the thumb IP joint. That one becomes sore, a joint fusion is a good option. The MCP one, which is the one in the middle of your thumb, that one often becomes unstable if there's osteoarthritis there. So stabilizing that with a fusion is good to do too. But then you got the base of thumb joint, and I think that's the most interesting one. That's the one where your thumb meets your wrist. That's very frequently involved, and that's important to keep moving that joint because that's the one that puts your thumb opposite your hand where you need it to go. Treatment options there, if arthritis is very advanced, is to actually remove the trapezium bone, which is a small bone. It's about the size of a gaming dice at the base of your thumb. That's the one that's usually all involved with arthritis causing pain and trouble. If you remove that one bone, it gives up lots of free space for your thumb to move without the grinding of the bone-on-bone pain that you have. But the problem is that your thumb will want to slide into that void that you leave behind. So you need something to stabilize it. And for that reason, you do what they call a suspension plasty. which is stabilizing the base of the thumb metacarpal to that of the index metacarpal. So that procedure is called a trapeziectomy and suspensionplasty procedure. It's quite involved, but it's a good one. It's been around for a long time. Techniques have been refined and refined, and I find it leaves people with a pain-free thumb that moves almost as good as normal and is quite strong, but it takes oftentimes 3 to 6 months to get that full strength back.
How effective is surgery on the hand in general?
Yeah, it's effective. I really enjoy treating people with hand osteoarthritis because oftentimes they've had pain for years. They've been nursing a particular joint or a particular finger for a while, and then you operate and then suddenly it's pain-free. And I think if you get good pain relief, it's a successful procedure, and most of the cases that works. It's a successful thing to do.
When you've excised the skin to be able to get in and do this work, what's the healing like? Does it heal well, skin around the hand and the fingers?
Yeah, it heals well. Yeah, so oftentimes sutures stay in for about 10 to 14 days, and skin has healed in that amount of time. Your hands generally are favorable when it comes to healing. One main thing you want to avoid is scarring in a hand because scarring equals stiffness, and you want things to keep moving. Sutures need to be placed carefully and monitored carefully, and scarring needs to be addressed post-operatively with the hand therapists. They have lots of ways to keep scars supple and hands moving. Yeah.
So just finally, Paul, on this one, any advice or thoughts for doctors about osteoarthritis of the hand?
Yes, have a low threshold to refer people in. I know that I've seen a lot of people who had asked their GP about painful joints in their hands, and oftentimes they were said, "Oh, it's just some osteoarthritis. Have some Panadol and see how it goes." And so I think have a low threshold to refer a person in for hand therapy or hand surgery is a good thing to do. And if you do, send them in with a new X-ray of their hands. It's very helpful for that initial consult for a hand surgeon to have the X-rays ready to go.
Paul, continuing now, I want to shift gears. What is a ganglion cyst?
Yeah, a ganglion cyst it's the most common hand tumor. It's benign. It's non-cancerous. It's like a fluid-filled bump of fingers, hands, or wrists. It's like a little balloon with the stem originating from either the joint capsule or the flexor tendon sheath. And they can get quite big, but normally on presentation you see them at like 1 to 3 centimeters across. But the biggest one I've seen was like the size of a chicken egg on the back of someone's wrist. So they can get quite big. Now, if you examine them, they're not attached to the skin, so you can move the skin over the top of them, and they're usually not painful to touch. But they can cause discomfort, particularly wrist ganglions. When you put the wrist under load, like when you do a push-up or something, for example, they can cause a bit of tenderness. Now, a fun thing to do, an easy thing to do, is if you examine them, you can try and shine a light through them. If you have like a large cyst on the back of your wrist, for example, you shine a light through, you can see that it's a clear fluid that's inside. You can see it light up like that. So it helps you with your diagnosis. Now, the most common sites for these ones to occur is on the dorsal wrist and the volar wrist. And oftentimes they're sitting around the scaphoid bone, so on the radial side of the wrist. Sometimes they can arise from flexor tendon sheaths of fingers or from the DIP or PIP joints. They can develop after a minor trauma or repetitive trauma or as part of osteoarthritis.
One of the treatments that came across was the Bible bump. Is that a useful treatment?
It's entertaining, but it doesn't really work. Now, the Bible bump means hitting the ganglion cyst with a heavy book, like a big Bible, and it will rupture the cyst, and it will pop, and the jelly-like fluid will disperse under the skin, but the root and stem of the cyst still remain. And so there's quite a good chance that it will come back. Now, there's some entertaining YouTube videos available of people doing this Bible bump treatment, but I wouldn't recommend it. And it often just results in a recurrence.
In that case, we'll skip my next question, which was to ask whether the King James Version or the Revised Standard Version was your preferred tool.
The heaviest one, I guess, if you have to give it a try. Yeah.
Now, can these cysts spontaneously resolve?
Yes, they can. I've done a small literature dive into this. There's reports that say 30 to 50% of these cysts can resolve spontaneously. I guess that's true, but it varies a lot, of course. If you had a minor trauma and a cyst pops out and it's been there for a short while, you might just want to sit it out and see what happens. But if a cyst has been there for many months, I don't think it's going to self-resolve. It's just a matter of how much are you willing to put up with it too, of course. Are you going to wait for it for a year or 2 years for it to resolve on its own? So the answer is yes, but it's unknown which ones do and how long it will take.
So what are the treatment options for ganglion cysts?
Yeah, I think as always, non-surgical ones should be considered first. Now, don't do the Bible bump. I think that's just, it's not very necessary, but an aspiration is a good first go. So you can needle the cyst you have to use a sizable needle because the jelly inside is quite thick, and you can aspirate the cyst that way, so empty it. It's even better if you also inject a cortisone, a steroid, through that same needle back into the cyst area. That reduces the recurrence rates. Now, it could be quite useful because about 3/4 of the people who have an aspiration actually have some temporary relief of the symptoms, but there's about a 50 to 60% recurrence rate, even if you do the aspiration very well. So there are non-surgical options. Mostly it's aspiration with or without a cortisone injection.
Does the steroid help to reduce recurrence, or are we talking about pain relief there?
Yeah, so as a standalone, the steroid I don't think is very helpful, but if you do an aspiration and leave a steroid behind, then it reduces, well, according to the literature, the recurrence rate from about 50% of aspiration only to about 15%, which is 1 in 6. Yeah, so it's a useful addition. It will help with the inflammatory component too, and with that you get some pain relief. It's always worth a try. So people who I see who haven't had any treatment to their ganglion cysts, I will always opt to say, try the aspiration and cortisone injection. And if it fails, we will consider the operative approach.
Now, what surgery is available for these?
Yeah, you can excise the cysts. And the main deal is that imagine this, balloon with its stem stuck in the joint capsule, is to remove the whole balloon and its stem and a little rim of the joint capsule as well. Because the going therapy is that theory is that the ganglion cyst arises from some degeneration of the joint capsule. So if you excise a little donut of joint capsule as well, it reduces the recurrence rates. So a surgical excision is a good way to deal with it. It's a day surgery where people will come and go the same morning or afternoon and have their cyst removed that way.
How common is the recurrence?
In literature, it's wildly varied. Some people have reported 1% recurrence rate, and other studies have reported 50% recurrence rate. I've done an audit of my practice. It sits about 3 to 5%.
So, Paul, are there any final thoughts or advice you have for doctors about ganglion cysts?
Yeah, so don't try the Bible bump. But I think a first good port of call is to send a patient in for a radiology referral for an ultrasound-guided aspiration with cortisone injection. That's a very good and useful first step, and it keeps approximately half the people out of an operating theater. I think that's a good first step to take.
Continuing our conversation now, Paul, I'd like to ask you on a different note altogether. What are some common presentations of patients with carpal tunnel syndrome?
Yeah, carpal tunnel syndrome is compression of the median nerve at the level of the carpal tunnel, so where the hand meets the wrist. Now, the median nerve there is a mixed nerve, so it means it's got both sensory and motor function. And so the symptoms of carpal tunnel syndrome can be both sensory and motor. Now, the sensory ones are more common, and the typical presentations are that people feel pins and needles in their thumb, index, middle, and the radial half of their ring finger. That's the area the median nerve takes care of for sensation. And these pins and needles can progress into numbness during the day or at night, or even permanent numbness. Now, a very typical presentation is that people say that they wake up at night with pins and needles and pain in their hand and forearm. So usually they're fine during the day. They do a busy day's work and everything is okay. They go to sleep, and then at 3 a.m. they wake up with pain and cramps in their hands with pins and needles. That's a very typical one. Now, other presentations are when people say when they're driving their car, their hand feels crampy or the fingers go tingly, and then they need to rest their hand in their laps off the steering wheel for a little while, and then the symptoms go away. So those are the sensory ones. Then you have the motor symptoms. Those are usually present in more advanced cases. You can get weakness of your thumb with wasting of some of the thinner muscles of the thumb. You can see the difference between the two hands, and it can cause clumsiness. People say, I keep dropping the dishes because I can't feel the dishes in my hand when I'm lifting it, and I don't have the grip of my thumb strength available anymore to do these things. So I keep dropping things. It's a common problem, and these symptoms are usually quite telling. Oftentimes, you can make the diagnosis by just listening to the history of what they have to say.
Are there any useful tests for assessing carpal tunnel syndrome?
Yeah, so there's physical examination tests you can do. Like the three classic ones are the Tinel sign. The Tinel sign is a test where you tap on the median nerve. You can tap on the median nerve quite firmly. You start in the distal forearm and then move your way up to the hand. If a nerve is irritated, like in case of carpal tunnel syndrome, it will give patients a sensation of tingling or zapping or an electrical sort of buzz. Is called a positive Tinel sign. A second test you can do is the Durkin test. Now, the Durkin test involves putting your thumb on the patient's carpal tunnel and push down for about 30 seconds. So you increase the pressure in the carpal tunnel doing that. And if you wait, people will report that they're getting their carpal tunnel symptoms. So the pins and needles in the fingers start again. That's the second test we can do. And the third one is the Phelan test. Now, the Phelan test means you place the patient's wrist in full flexion. So you force the wrist all the way down with their fingers relaxed down. And that way you put some more pressure in the carpal tunnel too. And that usually gives symptoms in about half a minute too. So those are the three physical examination tests you can do. And sort of more advanced ways to look at it is to do an ultrasound scan. Ultrasound scans are quite reliable. They report on what the nerve looks like. Is the nerve swollen or crushed under the transverse carpal ligament? And those are quite reliable as a diagnostic. And then you have the gold standard test, which is the nerve conduction study. And that can be done by neurologists. And a nerve conduction study measures how well the nerve conducts electrical pulses, and it will show you how the nerve functions. So the ultrasound is a good way to see how the nerve looks. And a nerve conduction study is the sort of gold standard to see how it functions. Now, I find you don't always need these advanced tests to diagnose and treat carpal tunnel syndrome. But if you have medical legal reasons or a case that's not as typical in presentation, a ultrasound scan at a minimum is a good way to do it. It's more comfortable for the patient and easy to obtain. Or you get the nerve conduction study, and then you have the actual nerve function presented to you in numbers.
So what are some of the useful non-surgical treatments you have?
My first protocol is nighttime splinting. what often happens is people wake up at night, in the middle of the night, with carpal tunnel syndrome symptoms. That's often because people tend to sleep with their fists balled and their wrists bent. And that creates basically one of those Phelan tests of their own in the middle of the night. And then they wake up because their nerves are crushed. So if you put the wrist in a splint that keeps the wrist straight, then oftentimes people sleep through the night, that first night they use it. And some prefer to avoid any other form of treatment and sleep with two wrist braces on for years and years, keeping them asleep at night without carpal tunnel syndrome symptoms. So I think it's a good first option. It doesn't burn any bridges and it's non-invasive, but people have to commit to wearing these splints. And oftentimes in summer, they think it's too hot or too uncomfortable. And personally, I wouldn't want to sleep with a wrist brace on every night, but it's a good first option. Now, other options can be considered. You can try some anti-inflammatory medication for some cases, or you can try a cortisone injection around the median nerve. And again, I think that's best done with a radiologist there under ultrasound guidance, because obviously you don't want to inadvertently inject the nerve itself, but you want to make sure you place the cortisone in the right spot.
So when you're looking at surgery, when is that the best option?
When you have an established carpal tunnel syndrome. So some people never have any hand problems. They have a sedentary job, work on a computer, and then they decide to move house. They're very busy. And over the course of 3 days, they're lifting all these boxes and they develop carpal tunnel syndrome. Oftentimes for those people, surgery is not required. You can just rest your wrist, try some anti-inflammatory medication, maybe a cortisone injection, and then oftentimes it just settles down and the carpal tunnel syndrome is gone. If it's more established and the nighttime splinting doesn't work anymore, I think a carpal tunnel release should be considered. And it's a safe and well-tolerated procedure to do. So I think the threshold for a carpal tunnel release is fairly low. It works, it decompresses the carpal tunnel, and it's in most cases a permanent fix.
When you're talking surgery, like the actual surgery itself, patients must get caught because it feels like you're literally cutting wrists. And so is that actually a conversation with the patient as to what the surgery is, the slice and the cut and everything?
Yes, I actually have a printout laminated sheet of a hand anatomy where it shows the nerve going under the transverse carpal ligament of the wrist. And I explain, like, this is where your nerve is under pressure, and this band that's sitting over the top is restraining it. And if we open this band, then the space is decompressed and you'll sleep through the night that same night. So I actually have that conversation. I draw on their hands where the surgical approach will be, and explain to them what you're doing. And it's an interesting question. I never had a person recoil saying, "Oh, you're cutting my wrist." But yeah, that's an interesting thought indeed.
I was just wondering, because it's just like people saying cutting wrists and everything, when you actually got the band under there. I'm just trying to work out, because you're actually cutting a band, how long does that take to heal?
Recovering, it goes quite well. So skin heals in about 2 weeks, and people can return to trying a hit of golf, for example, and doing some more things with their hands. If you want to do heavy use treatment, like laying brick and heavier use, it takes about 6 weeks. And in some occasions, you do need to do a redo carpal tunnel release, for example, and you see the transverse carpal ligament has healed, has just grown over again, but then again with some more space underneath. But yeah, it does take about 6 weeks for that ligament to scar over, basically. Yeah.
And so prognosis is good for patients with carpal tunnel surgery?
Yeah, it's excellent. So the surgery is well tolerated, and people often love not having those night wakes anymore from the day of surgery. It's a very good operation. There's there's a clear anatomical reason why people have carpal tunnel syndrome, and there's a clear anatomical fix for it by doing a carpal tunnel release. So yes, the patient can go home same day. They can use their hands and fingers before they leave the hospital. On day 3, the bandage comes off their hand and they can shower and drive their car again. And then at 2 weeks, I advise them they can start doing some moderate activities. And at 6 weeks, they can go back to hard use. And recurrence rates are low. I prefer to do the open carpal tunnel release, which is a direct approach to the median nerve. It shows me the nerve, I can safely dissect around it. And recurrence rates are very low, approximately 0.5% or so. And then there's the endoscopic carpal tunnel release, which is an inside-out carpal tunnel release through an endoscopic procedure. That has a recurrence rate which has been reported to be about 3 times higher, at about 1.5%, which is still not much. But if you do 100 of those in a year, then you will see 1 or 2 patients with a recurrence. So that's why I prefer to do the open procedure.
So when should a patient be referred to a surgeon for this?
Yeah, I think if someone has an established carpal tunnel syndrome, carpal tunnel release should be considered. But if there's a clear onset, like the case I discussed before, someone starts moving house and somebody has some carpal tunnel symptoms, you can try the night splinting and, let's say, a cortisone injection, for example. But if it's a more established one, has been present for a few months, or it's very advanced, then please refer in, because the carpal tunnel release surgery works very well.
One thing I just wanted to raise, because it's a common theme that's been throughout each of these topics, is the radiology. And is this a certain point where you have a special relationship of people, of radiologists who are specialised in these kind of, because these are pretty specialised areas that you're doing, or is this a general, any radiology department will be able to do it?
Well, when it comes to treating carpal tunnel syndrome, any radiology department should have the knowledge to do this. There are very clear radiology guidelines that define the cross-sectional area of the median nerve at the carpal tunnel. And if it meets a certain threshold, you can consider it a positive test. And to do an ultrasound-guided cortisone injection in a carpal tunnel should be fairly easy to do for any radiologist. Now, I'm not a radiologist. I shouldn't really speak on their behalf, but it's not the most complex thing they would do. So any radiology department should be able to do this safely. But that said, of course, as a hand surgeon, you do have your preferred radiology departments, people you often work with and that you trust will do an excellent job every time. And so, yeah, there is that relationship, of course.
And just one last question on behalf of a friend of mine who gets squeamish very easy. If they came to you for this and you've got that lovely diagram, are they able to say, I'd rather not see it, Paul, just do what you need to do?
Of course, they can always say that. And key thing is make sure your patients are comfortable at all times. But I find a well-informed patient, it does better. Like they know better what's going on with their procedure, what to expect afterwards. So I think clarity is important. But yes, no, I won't try and make people uncomfortable by showing them pictures they don't want to see, of course. Yeah.
And do you have any final advice for doctors about carpal tunnel syndrome?
2 things. First, I think not everybody needs a nerve conduction study or an ultrasound scan. Getting a nerve conduction study isn't always easy to do. Waitlist can be quite lengthy. So it is not a requirement to have a nerve conduction study to send a patient to a hand surgeon. If symptoms are there and quite typical, then you can just refer in with or without an ultrasound scan and have a fairly low threshold to refer, because I think a carpal tunnel release is safe and effective, and people love those results.
Dr. Paul van Minnen, thank you again for returning to This Medical Life.
It was a pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is at Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.